So, welcome to some more Unit One content. Now we're going to move on to the kidneys. This is Chapter 47, Assessment of Kidney and Urinary Function. So, first, we're going to just give into a basic overview reminder of the kidneys from A and P patho. But they're these bean shaped. I don't know if kidney bean came first or kidneys were found and those beans look like kidneys, so they call them kidney beans, or I don't know. I'm not sure of the name, but kidneys is kind of your layman term for them. A lot of times you'll hear the kidneys called a renal system is kind of the whole thing. And then the kidney itself is usually neph. So a doctor that studies the kidneys or works with kidneys is a nephrologist based on what kidneys mostly are nephrons. So, I mean, overall, the renal system is the kidneys, the ureters, two of them from each kidney, bladder, and urethra, and then out the body. And the whole goal is forming urine, which job is to excrete waste. But the big other things the kidneys does is regulate electrolytes, control water balance, control blood pressure. So if you're thinking anything from urine trouble to electrolytes, water, and blood pressure, then you're thinking kidneys. Just a summary again, how the kidneys work. There's millions of nephrons that run throughout the kidneys, different layers. It's on the outside cortex and then a medulla on the interior. But each nephron has what's called a glomeralis, has an artery that comes into the glomeralis and an artery that comes out. And it's extremely high pressure, and that pushes substances, electrolytes, fluids out of the glomeralis and into the nephron tubes. And then the tube's job is basically what's reabsorption and secretion. So they're going to slowly, things are going to get reabsorbed from the tubules back into the bloodstream, stuff we want to keep, and stuff that stays in the tubules and eventually makes it to urine is stuff we want to get rid of. So, a million nephrons in each kidney, lots of blood flow through the kidneys, regulation of blood pressure, and then basically just micro drop by micro drop, urine is produced through all these nephrons. They collect together, and then eventually they're going to collect in the interior of the kidney. It's called the renal pelvis, and then they're going to go to the ureter, down to the bladder for holding. Bladder gets full, you have to pee, urethra, toilet. So more of a zoomed in picture of what's happening. Just keep in mind that blood flow is super important for the kidneys. I mean, you can see that because blood comes in through all these million nephrons. Blood's going to come in the glomeralis here. It's like a little swirly high pressure, pushes out into what's called a Bowman's capsule. And now you would call this filtrate, if you remember a little bit. This is not exactly blood anymore. It's not just water. It's full of stuff. It's filtrate. And as the filtrate makes its way through the tubules, pressure changes, osmosis, oncotic pressure, hydrostatic pressure will push certain things back into the bloodstream, things we usually want to keep. And then eventually, what will make it up into the end of these collecting ducts that meet together is stuff we want to get rid of: uric acid, ammonia, things like that. And the kidneys both have their own dedicated artery. So one big thing to note now, we'll talk more about, is what's called GFR. We're talking about glomerular filtration rate, GFR. There's a lab test for this, but GFR as a whole is just the rate in which the glomeruluses of all the kidneys filter fluid. And it's about 180 liters a day, but only about 1 or 2% of that actually makes it to urine. Most of that filtrate substances and a lot of water get reabsorbed. So it's just about pushing out a lot and then letting the renal or the kidney, excuse me, the nephron tubules slowly kind of collect back until what's left is just concentrated waste. And there's two arteries you see here coming into this glomeralis of every single nephron, but there's an afferent or efferent with an E and an afferent arteriole with an A. Efferent is carrying blood away, it's leaving. Afferent with an A is coming in. And again, it comes in one artery, branches off a bunch to form a glomerulus that increases pressure and pushes stuff out. And then it actually comes back out, and this artery will form like a capillary bed around the nephron so that it can recollect or reabsorb things that it doesn't want to. We don't want to lose necessarily. Gerontological considerations. So for your older adults, GFR itself, that glomerular filtration rate of 180 liters a day, is at some point going to, eventually, it's going to um, slowly um, gerontological considerations that GFR eventually starting age 35, 40 is going to slowly slow down. Again, we'll talk more about GFR, but it's a great test. I'll mention this now as kind of a need to know. GFR is a great test for just general kidney function as far as lab values go. GFR is going to kind of consistently tell us the liters that were being pushed into filtrate. And if that number is declining, then that's indicative of poor kidney function. And in older populations, it's always decreasing a bit. Also, with the fact that they're more susceptible to kidney injury, they have decreased thirst response, maybe increased salt because they have trouble, getting rid of it. Prostate issues for men are going to slow up urine flow and then maybe cause backup. Incontinence could lead to urinary tract infections, poor hygiene, and then just decreased mobility. But the GFR is a great indicator of this because it basically attests that how well the kidneys are working. It just says how much blood is passing through the glomeruli, all the glomeraluses, each minute, basically. So kidney functions, again, summarizing big stuff: acid base imbalance, electrolyte balance, regulation of blood pressure. Kidneys also help us produce blood cells, a hormone called hemopoiesis. Hematopoiesis is goal is to help basically get the bones to generate more blood cells. So kidney issues. So think through this as what's the issue going to be then, right? Not enough electrolytes, electrolyte imbalances, acid base imbalance, acidosis, alkalosis, blood pressure regulations, probably high blood pressure. And the kidneys are messed up, then maybe anemia, not enough blood cells. Other things to note: vitamin D synthesis. So vitamin D is a vitamin we absorb through our skin from UV radiation, but to activate vitamin D is kind of the kidneys need to activate that vitamin so we can actually use it to help us produce things that we need, formulate calcium, that sort of stuff. There's some prostaglandins made by the kidneys. These are involved in inflammation and injury. And then just obviously excrete waste. But you got to think these top four and excrete waste as the kind of biggest things with kidneys. Think about what would be involved in basically them not working anymore, right? So, which of the following is not a function of the kidney? Give you a second to look this over. If you answer number 2, you're on the right track. Does everything else, doesn't do anything with blood glucose. About everything else, but not blood glucose. So assessment for everything is always going to be a thorough health history, and then obviously a physical assessment. Things that you'd be thinking about, risk factors or stuff that could lead to any kidney issues or urinary development, history of UTIs, painful urination, which is dysuria, hesitancy, that just means that people have like issues starting a stream, or being able to pee, hematuria, that's blood seen in urine. Caffeine and alcohol consumption are risk factors for renal or urological disorders. Table 47-1 in your book's got some more. So again, health history, review the factors, and then when it comes to urination, what's the changes in urination? So these are some of the words that are worth knowing here on the right. These are nice to know / need to know terms. Most of them you're going to see again in the future, but you really just need to go ahead and let's say need to know on the terms on the right here. So anuria basically is no urine production. You would see this in a patient that has total kidney failure, dialysis patient, end-stage renal disease. We'll talk more about that in the next chapter. Dysuria is painful urination. Hematuria hemo. So it's blood and urine. Oliguria just means decreased urine output. Typically, it's categorically it's less than 300 milliliters in a 24-hour period. That can change on what book you're reading, but it's low, 350 milliliters an hour, somewhere in that range. Polyuria is poly means many, so poly is excessive urination. You'd see this in a diabetic patient or someone with diabetes insipidus. Proteinuria means pretty straightforward protein in the urine, and nocturia means getting up at night and having the urge to pee at night while sleeping. So, what's the medical treatment for decreased urine output? Or what, excuse me, medical treatment? What's the medical term for decreased urine output? Decreased. Just said what's decreased urine output? This is the common one you're going to hear a lot. It is number one, oliguria. You would say someone's oliguric if they're not peeing enough in that time period. What's the term for presence of blood in the urine? This one's obvious because blood is made of what component? Hemoglobin. So it's hematuria. Physical assessment, things they're looking for is definitely like pain, localized, and then changes in voiding. I mean, that's the big assessment factors. Does someone have pain? Do they have changes in the way they normally pee? If their normal urine is this way, then maybe that's their baseline, but we got to figure out why. So people can physical assessment can be like physically palpating the kidneys. Percussion is basically taking a hand over the back of the kidney and hitting your hand to see if the vibrations cause any tenderness or pain. Check for ascites. That's just looking for fluid third spacing, which would be kind of a side effect of poor kidney function. Making sure they can empty their bladder, looking for edema, again, fluid buildup. And then there's a prostate exam, which is palpating the prostate to see if it's enlarged in men. Men only have prostates, not women. Women could go as far as pelvic exams. So how you diagnose things with the urinary system? Most of the time, it's these big three. It's going to be a UA, a urinalysis. They may take that urinalysis and do cultures, which means they're going to take a smear of that, put it in a tray, see what if any bacteria grows, and that takes time. And then just urine examination in general, like visual examination of urine, other tests of the urine, and just again physical assessment of how their urinary function is. So urinary labs, a UA is basically looking at kind of a whole picture of a urine sample. So color, clarity, the pH balance, is there sediment in it? What's it look like visually? Cloudy color, white blood cells, is there presence of bacteria? Those kind of things. Cultures are looking for bacterial growth and also to help us find out what they're sensitive to. A big one is specific gravity. Urine specific gravity is one. That range basically talks about urine concentration, basically kind of the concentration of sodium, but of other solutes. So how is it compared to distilled water? So urine should be a 1.05 to 1.025. And so if urine specific gravity is rising, that would basically indicate that someone's blood is much more like concentrated. If urine specific gravity is low, which is more rare, I mean they're like overhydrated or more of a hypo volume sort of thing. It's more rare. It's definitely more common to see increases in urine specific gravity. And then 24-hour urine collection. That's more about detecting, evaluating the progress of kidney disease. So if someone is a candidate that they think is, in some kind of chronic kidney disease, they can do a 24-hour urine and compare GFR and other labs and go, okay, so we can see that's basically 24-hour urine is all about evaluating the progression of kidney disease. And note with cultures too, they take time. Going back to cultures, most cultures, there's always preliminary results in 24 hours, but usually it's 2 to 3 days before you see full bacterial growth. And then that's when you can get an idea of what antibiotic is going to battle or fight this organism. And that's why we have broad spectrum antibiotics to try and catch multiple bacteria until we know specifically what it is. So normal values for a UA are over on the left. Color, light pale, clear versus cloudy. Cloudy usually indicates infection. pH, specific gravity, again, typically that's going to be on the rise. And so if there's dehydration or more concentration in the blood, glucose, we shouldn't see a high amount of glucose in our urine. We need that. We use glucose a lot in our body for energy production, those sort of things. So shouldn't find those. Ketones, shouldn't find. Nitrites, shouldn't find white blood cells, shouldn't find um, really being bilirubin. That would indicate liver issues. Should find minimal amount of protein, minimal amount of red blood cells and white blood cells. That can indicate infection to physical injury to urinary tract, those sort of things. Shouldn't definitely find yeast or bacteria. I would say probably one thing I always note with these, and we'll look at another one too, but like one thing I always know, if you want to know 100% of the time that someone has a bacterial UTI, if nitrites is positive, this is a nice to know for the future, not a test question necessarily, but it's good to know. It's really, really good to know. This will save you a lot of trouble when you're looking at lab results on a patient, because you can look at everything and be like, but as soon as you see nitrites positive, nitrites, basically, nitrate is something that's processed by bacteria. Bacteria use nitrate, and when they use nitrate up, they turn it into nitrite. And so, if there's any nitrites ever in someone's urine, you're pretty much guaranteed they have some bacteria somewhere that's causing infection, because nothing in our body processes nitrates into nitrites except foreign guys like bacteria. So, that's nitrite positive. You're like, okay, they've got a urinary tract infection, because that shouldn't be there. Basically, that's only if they have bacteria. So hopefully that kind of helps. um, and this is just an example of a urine culture. A goal of a urine culture is to identify the organism. In this case, it's showing E. coli, which is very common, because E. coli is very prevalent in our GI tract, and our urinary system is in close proximity to our anus, and potential risk for contamination from stool. So E. coli, if you wanted to highlight the most common bacterial UTI infection, urinary tract infection, we'll talk about UTIs a little bit more. It's going to be E. coli, but this just tells us what antibiotics is this organism sensitive to, and that helps the doctors and determine, what's the best course of action for um, antibiotic treatment. So on specific gravity, again, this is like the density or concentration basically of urine. Um, so this urine specific gravity, we're talking about labs, depends highly, highly on hydration level, real highly on hydration. So if someone is fairly well hydrated, it's going to be on that low range of normal. They're going to be starting to make it to significant dehydration and needing water once they get to that higher end of like 1.021 and above. And then anything outside the normal range into the 1.03 is like some serious dehydration, need correction. So as urine specific gravity rises, it's basically saying that the body as a whole, systemically, and the blood specifically, is much more concentrated, which would be an indicator of dehydration. The 24-hour urine collection, again, basically is kind of helping us measure the volume of blood cleared, kind of helping us to determine GFR and diagnosing. It's basically the 24-hour urine collection is basically a gold standard. So I'm gonna say this needs to do. 24-hour urine collection is basically the gold standard for diagnosing progressive kidney disease. So if a doctor suspects someone has chronic kidney disease and they want to know kind of what their staging is and get an idea of comparing their GFR and labs and taking urine to understand, they're going to do a 24-hour urine. So 24-hour urine collection is basically for diagnosing or ruling out chronic kidney disease. And basically, this is kind of, they get a good measurement of GFR, and they get a good measurement of, because comparing the number of urine output to their GFR blood work, they also get a good idea of how much your kidneys are clearing something called creatinine. Creatinine is another lab I haven't highlighted yet, but creatinine is something that also elevates with urine specific gravity. It just basically, creatinine is an indicator of decreased kidney function, just like GFR is, because the creatinine is on the rise. This is an enzyme that's made and processed, by your muscles, and so it should be cleared by the kidneys. If it's starting to rise in your blood, it means the kidneys aren't clearing it, which also indicates progressive kidney disease. So specific gravity is more about hydration status, creatinine levels on a blood test are more about kidney function. Then you would do a 24-hour urine and look at 24-hour urine collection, and you would look at GFR on labs to kind of diagnose chronic kidney disease. So here they are again. Another one is BUN, which stands for blood urea, nitrogen. Blood urea nitrogen is basically we are supposed to get rid of nitrogenous, that's such a tough word, nitrogenous waste and urea in our urine. That's kind of where urine gets its name, is mainly uric acid. And we want to get rid of that uric acid. Nitrogenous waste is all waste products from our cellular metabolism. So blood urea nitrogen measures like this ratio basically of urea and nitrogen in blood, and it should be in the range of 7 to 20 milligrams per deciliter. So as that rises, basically, or excuse me, as BUN rises, as creatinine rises. So when you think of abnormal labs for kidneys, right? Kind of make it a big three here. The 24-hour urine collection again is for creatinine clearance. This would be DDXing, diagnosing chronic kidney disease. Diagnosing chronic disease. And if creatinine's on the rise, BUN's on the rise. I'm not going to worry too much about BUN creatinine ratio necessarily. And GFR is slipping, getting lower than this 60 to 100 milliliters a minute kind of range, then we have progressive kidney disease. And again, this chart shows you that if we're under 15 milliliters per minute, we are like kidney failure. And kidney disease would be basically anything that starts to trend underneath 60, but if 60 milliliters a minute. But yeah, if we are in the 15 milliliters a minute, we are in full on kidney failure. So a BNP is a kidney function. Basic metabolic panel is going to have our kidney function on it. Looking at then most doctors are looking at BUN creatinine, maybe urine specific gravity if they don't think it's kidney failure, but like geriatric or just adult dehydration. You're going to look at red blood counts. You want a CBC, and then ABGs because our kidneys are such a role. The BNP is going to look at electrolytes and kidney function. CBC is going to look at red blood cell counts to make sure, that production's okay. And then ABGs are going to look at acid-base balance because remember, our kidneys regulate fluid, acid-base balance, and electrolytes. They're the main guy that does that. They're the main organ that regulates those big three. So these are all things that have to be considered when someone's getting worked up for kidney failure. What diagnostic test examines color, clarity, and pH of urine? This is pretty easy. That is correct. If you picked, I don't have my mouse clicker. If you picked the urinalysis, that's correct. Color, clarity, pH, general, holistic. What's the normal range of specific gravity? Again, to give you a second to pause. You answer number 4. You are correct. What does a 24-hour urine collection help us to evaluate? Again, pretty straightforward. Just talked about it. What is it? Progression of kidney disease. Where's it at? Normal range of BUN. BUN. What's the normal range of blood BUN when we measure it? This one's a little bit of a weird number. I always try to remember that it starts with 7 usually. So 7 to 20 milligrams per deciliter. Kind of a few more notes here. I don't know if any of you have ever seen a bladder scanner before. When we talk about assessing or diagnosing or understanding urine problems, this is more in line with physical problems with urination. So if you ever seen a bladder scanner, it's like a little mini ultrasound machine that's really easy to use. But basically, it comes with gel. It has a scanner like the woman here in the picture showing. And this would be a post-void residual scan, basically, most of the time. What it's basically, a mini ultrasound machine that you can set for a female or female without a uterus, because it kind of changes how it's going to try and scan the image. But what you're doing is looking at the bladder, usually, again, post-void residual is what you're looking for here. So after someone voids, do they have a lot of residual urine? So for most people after going pee, they should have 50 to 100 milliliters. So like this picture here, this person that has 331, if that was after going pee, then that's you're categorically that's urinary retention. We'd want to figure out why that's happening and what we could do to help them. Other renal function tests, a KUB is a kidneys, ureter, bladder X-ray, basically. So it's a KUB is looking at all the renal system, kidneys, ureter, and the bladder. Ultrasonography is basically just ultrasound. It's looks for fluid accumulation, masses, tumors, right? Something obstructing the bladder flow. Um, this one, ultrasounds are interesting. The bladder actually needs to be full before so that the bladder can be big enough and they can get proper scans. Um, Pylonography is a catheter goes in to the renal pelvis and the means of a cystoscopy, and they inject a contrast. And cystography evaluates basically backflow of urine. Renal angiogram, that's looking at the blood flow. Any angiogram is looking at blood flow, so that's usually dye, visualizing the blood flow. Cystoscopy in general. So out of these, I just highlight what a KUB is. Cystoscopy. Um, Cystoscopy is just a kind of a rigid, semi-rigid cystoscope or cytoscope goes into the urethra, into the bladder to visualize the urethra, visualize the bladder and other like lower renal system functions. And then obviously a biopsy would be to help diagnose usually kidney disease or cancer. And these are some examples. There's the pylography where we're injecting the dye. Arteriogram, a dye injection to look at the blood flow through the kidneys. KUB, right? We're doing an X-ray to visualize these organs. Kidney ultrasound, again, depending on what they're using it for. Um, it depends on what they're looking for. Could be looking for masses or malformation of the kidney. Male and female cystoscopy. With a lot of procedures, especially any of these procedures like a cystoscopy, where we're advancing some kind of foreign instrument into the urethra. What do you think the most likely side effect after they have this procedure is going to be? Yeah, if you guessed hematuria, bleeding, blood in their urine, you're 100% correct. And then a biopsy is just you're going to find the kidney with ultrasound, take a biopsy instrument, needle, uh, puncture the skin, grab a piece of tissue, and then analyze it. So that summarizes basically quickly chapter 47. We'll move on to chapter 48 and 49 to kind of wrap up the kidneys. Thanks for, I'll do that in the next video. So